Okay, Parkinson's disease. There's no way I'm going to get this in under 10 minutes, but I'm going to try. It is a progressively debilitating disease that really affects motor function. There's 4 primary symptoms, which would be tremor, muscle rigidity, bradykinesia, which is slowing of the movement, and postural instability, so they're tippy. These symptoms occur due to overstimulation of the basal ganglia by acetylcholine. The secretion of dopamine and acetylcholine in the body produce inhibitory and excitatory effects on the muscles, respectively. And overstimulation of the basal ganglia by the acetylcholine occurs because there's a degeneration of the substantia nigra, which results in a decreased production of dopamine. What happens then is it allows the acetylcholine to dominate, making smooth, controlled movements very difficult. So when treating Parkinson's disease, or PD, the focus is on increasing the amount of dopamine or decreasing the amount of acetylcholine in the patient's brain. This is a progressive disease, like I said before, and there are 5 stages of involvement. One is a unilateral shaking or tremor of one limb, and this can be very, very minimal, like just even a couple fingers to begin with. Stage 2 is bilateral limb involvement, making walking and balance difficult. Stage 3, the physical movements slow down significantly and affect the walking more and more. And by 4, the tremors may decrease, but akinesia and rigidity may make it very difficult to achieve activities of daily living. And then in stage 5, the client is usually able to have difficulty standing or walking, and they're dependent on all their care. And they may even exhibit dementia. So the risk factors, we usually see this between ages of 40 to 70, most often in men more so than women, and there is a genetic predisposition, and exposure to environmental toxins is also a risk. The patient themselves report fatigue and a decreased manual dexterity over time, so they actually see that they're having difficulty with fine motor movement. Okay, so what will we see in these patients? And I like these little pictures that I stole off the internet somewhere. I have no idea where I got them. GoogleImages.com, I'm sure. Anyways, so what are we going to see? Their patient will have a stooped posture. They'll have a slow, shuffling, and it's a propulsive gait, so they sort of pitch themselves forward and they have a hard time stopping. They get going and then they're sort of propulsed forward. They may have a slow, monotonous speech, so they're very monotone. And the tremors, the classic one is the pill rolling tremor of the fingers, where you actually see them, it looks like they're rolling a pill in their hands, which I'm showing you now, but you can't see. They have muscle rigidity, bradykinesia, akinesia, a mask-like expression. And this is kind of unnerving talking to these people because they're truly very mask-like. Their expression of their face there is none. They have autonomic symptoms such as orthostatic hypotension, flushing, diaphoresis. They may have difficulty chewing and swallowing, puts them at risk for aspiration, drooling, dysarthria, progressive difficulty with activities of daily living, like I said before. There may be mood swings and cognitive impairment, which is possibly leads to dementia in some of our patients. So there's no actual lab tests that we do for these people. The diagnosis is made by symptoms, the progression, and to rule out other diseases. So how do we care for these individuals with Parkinson's disease? We're going to be giving them their medications at their prescribed times, monitor the medication effectiveness, and make any recommendations for changes in dosage or time of administration to provide the best coverage. We want to make sure their swallowing is okay and that we maintain adequate hydration. Probably consult with speech and language therapists for swallow testing. And we want to make sure that we don't have any aspiration risks. Probably a great idea would be to get a dietitian involved. We're going to document their weight at least weekly because if they're not eating, they're going to be losing weight. A diet log can be kept. Encourage fluids and document the intake. We don't want to dehydrate them. Small, frequent meals. We may add commercial thickener to thicken the food to decrease aspiration risk and provide supplements as prescribed. We want to keep them as mobile as long as possible. Early on, we're going to encourage exercise. Yoga is one that we often say would be great. It's also good for the mental status. We want to encourage use of assisted devices as the disease progresses, the little sticks with the grabbers, and other devices that help with activities of daily living, shoehorns, that kind of thing. Encourage range of motion exercises. These patients are at risk for fall because of that tippiness they have and that propulsion walk, so we need fall precautions. We want to teach them to stop occasionally when walking to slow down the speed, so therefore they reduce their risk of injury. Pace their activities, give them rest periods, and assist the client with their needs in hygiene and dressing, etc. We want also to promote their communication as long as possible. Facial muscle strengthening exercises with that mask-like face, they need to work on trying to keep the muscles working. We want to encourage the client to speak slowly and to pause frequently. And there we can have alternate forms of communications as appropriate, written word, computers, that kind of thing. And we're going to refer once again to the speech and language therapist. We want to keep a careful watch on their mental and cognitive status. We're going to look for signs of depression and dementia. We're going to provide a safe environment for them. No throw rugs to trip over, electric razors so that the men can continue to shave themselves without any injury. We'll have to look at the personal and family coping with this chronic degenerative disease. This is hard not only on the patient but on the family as well. Refer to community resources, support groups as needed, and involve a social worker or a case manager as the condition advances, financial issues, that type of thing. Usually the nurses are first to pick up on that. So medications, it can take several weeks after we begin to use them to see an improvement in the symptoms, and when the client is taking a combination of medication, maintenance of therapeutic medicine levels is necessary for adequate control. So the next slide is a great breakdown of all the medications, and I found that in an article that I assigned to you. I think it's called The Shakedown on Parkinson's Disease. It's great. You should read that article. So dopaminergics, we want to give those orally, such as levodopa. They convert in the brain to dopamine, and it increases the dopamine levels. It can combine with carbidopa, and Cinnamate is a popular name. That decreases the peripheral metabolism of levodopa, so therefore there's a smaller dose is required to make the same amount of dopamine available in the brain, and the side effects are less. Because these individuals have a medication tolerance and a metabolism, the client's dosage and administration's time have to be adjusted, because we can avoid periods of poor mobility if we do that. So we're going to need to monitor our patients for a wearing off phenomenon and dyskinesia, which is problems with movement such as tardive dyskinesia. It can indicate a need for the adjustment in the dosage and the time of administration, and for the need of the medication holiday if such is needed. Other meds are dopamine agonists, anticholinergics, COMT inhibitors, antivirals, and if you look on the next slide, those are described quite nicely for you. And in that article, which I encourage you to read, The Shakedown on Parkinson's Disease. Because this is a degenerative neurological disorder, long-term care and treatment has to be accommodated. Later signs of the disorder, the client needs referrals to speech therapists, occupational therapists, physical therapists, social services, possibly placement in a long-term care facility. Surgical interventions that we say are a stereotactic palidomy. I knew I'd slaughter something, but I'm not going to re-record this. Anyway, um, so what they do is they look to destroy a small portion of the brain within, and they do that through target an area with CAT scan or MRI, and then a mild electrical stimulation is provided through a burr hole to that target area, and that usually decreases the patient's tremors and muscle rigidity. The other surgical intervention is the deep brain stimulation, and that's where they actually put an electrode into the thalamus, and the current is delivered through a generator, much like a pacemaker. And then the current is to interfere with that electrical conduction of the tremor cells, and it decreases the tremors. So patients having these things, we're going to look for, with either intervention, any signs of infection, brain hemorrhage, stroke-like symptoms. With the deep brain stimulation, it's turned, the generator is turned on and off with a magnet, so you need to instruct the patient on how to do that. And their battery to that generator has to be replaced every couple years. So our total outcome, or our goal, is that the client's medication will be scheduled so that wearing off phenomenon doesn't occur, so that they maintain that level without crashing down and then their tremors arise. That we want them to ambulate safely with any assistive devices they need, and we want to give them adequate hydration and nutrition with an appropriate diet and thickened liquids. The complications, aspiration, pneumonia, I've kind of talked about that all along. Chewing and swallowing worsens as the disease progresses, which increases their risk for aspiration. So we want to make sure that we have them sitting up, have a nurse in attendance when they're eating, encourage them to eat slowly, chew, and have them in an upright position, and suction equipment at the standby if we need it. The second complication is that altered cognition or dementia, memory deficits. In advanced stages, they may exhibit an altered cognition, and therefore, as nurses, we're going to acknowledge their feelings, provide a safe environment, and develop a comprehensive plan of care for the family with input from all members of the healthcare team.